Everyone, and a warm welcome to this exciting webinar, which is a joint panel event on World Hypertension Day on taking the pressure off. So this initiative was jointly organized by the World Stroke Organization, the World Hypertension League, as well as the International Society of Hypertension. My name is Professor Alta Skitte, and I'm the immediate past president of the International Society of Hypertension. I'm based at the George Institute for Global Health in Australia, and I have the honor of introducing a distinguished panel that we have together today from literally all around the world. So this is fantastic, and we have some great experience that I'm sure we will all be discussing today. So I'll start off firstly by a quick introduction of the panel, and then we will follow a structured discussion amongst everyone. I also ask you, the members of the audience, please feel free to post your questions on the Q&A. And we also have on Twitter a live chat going on, so please feel free to also post any questions on Twitter. So firstly, let me introduce Professor Sheila Martins. She is a founder and president of the Brazilian Stroke Network. She's also the president-elect of the World Stroke Organization, the first woman and the first person from a low-middle-income country to hold that position. So fantastic to have you on the panel, Sheila.
Thank you. It's a pleasure to be here with you.
Thanks. Next is Dr. Bindu Menon. She is a senior consultant neurologist from Apollo Specialty Hospitals in India. She specializes in stroke and epilepsy, and she's the founder of the Bindu Menon Foundation, which provides free information on screening and treatment for stroke patients. And I would like to highlight that her work has on raising awareness of stroke as won a World Stroke Campaign Award. So fantastic to have you also on the panel, Bindu. You're on mute, Bindu, yes. Perhaps.
Thank you so much. It's a pleasure to be here.
Excellent, thank you. Next up is Professor Mayowa Ovalabi. He is Professor of Neurology and Dean of the Faculty of Clinical Sciences at the University of Ibadan in Nigeria. In Africa, I don't think he needs any introduction. He's the pioneer and chair of the largest consortium investigating cardiovascular diseases in Africa. He has also involvement in the Stroke Organization and also director of the World Hypertension League. So a very warm word of welcome to you, Mayowa.
Thank you very much. It's a great pleasure.
Right. And then I introduce Professor Neil Poulter. He is the director of the Clinical Trials Unit at the Imperial College London and professor of Preventive Cardiovascular Medicine at Imperial. He is the chair and principal investigator of the May Measurement Month Global Blood Pressure Awareness Campaign, and which he has established as a past president of the International Society of Hypertension. Great to have you also on the board, Neil.
Thanks very much indeed, Alta. Good morning, afternoon, or evening to everybody, wherever you are.
And last but certainly not least, Professor Daniel Lackland from the US. He's professor of epidemiology at the Medical University of South Carolina, and very well known also as past president of the World Hypertension League. Great to have you on the panel too, Dan.
Great, and it's wonderful. It's a great honor to be with good friends, good colleagues, and just a really solid panel. So thank you for this opportunity.
Right. So yes, indeed, everyone, I think as a brief introduction, everybody is certainly very well aware of the challenges we all face globally. It's not isolated even to one country. We are facing COVID-19 on top of several other health challenges. And therefore, I think it's really good that we have this fantastic discussion today, because we can't ignore or neglect cardiovascular disease and stroke during these challenging times. So what I would like to start off with the first question. So it's in this difficult times with existing pressures that we face in the health systems, why is addressing hypertension and stroke a global priority right now? I'll point this first one to Neil.
Thanks, Alta. Well, in many ways, I think this is an easy question to answer, because if we just look at the statistics, raised blood pressure is the biggest single cause of death around the world now. It kills about 30,000 people per day. And without in the slightest way trying to downplay the horrors of COVID, COVID has never killed 30,000 people globally per day, and it never will. COVID, to one extent or another, is going to go away over the next year, maybe 2 years, but it will relatively go away and will never kill 30,000 people a day. Raised blood pressure does. And that's going to get worse because the society is getting bigger, world population is getting bigger. On average, people are getting older. That means blood pressure is going to go up. So the number of deaths down to raised blood pressure is going to increase. So it puts it in perspective as something that we cannot ignore. And the next thing, Alta and colleagues, is that it's very cheap to measure blood pressure. It's dead cheap to do it. And you don't have to be a professor of medicine. Most people can measure blood pressures, even their own. So it's very cheap to do. And if you do find it raised, there are good effective measures lifestyle-wise to lower it. And if that's not enough, we've got drugs which, and I appreciate this doesn't apply everywhere in the world, but in general, they are cost effective. They are cheap agents, and they should become cheap everywhere if they're not already. So that's my answer to that question, Alta.
Excellent. Thanks, Neil. I want to hand this also over to Sheila. I think you focus significantly on blood pressure, Neil, and I think in terms of stroke, we also have to target that aspect. Is there anything you would like to add, Sheila?
Yeah, we know that cardiovascular disease are the main cause of death in the world. The first cause is myocardial infarction. The second is stroke, but in some countries, in low resource countries, stroke is the first cause of death, and hypertension is the main risk factor, as Neil told you, and is very cheap to measure and to control. We know the stronghold of hypertension in this disease. Above 115 millimeters of systolic blood pressure, you start a continuous increasing risk of stroke. And the blood pressure control can decrease 48% of the risk of stroke with low cost intervention. So really you have to focus in hypertension to decrease the global burden of stroke.
Thank you. Thank you. Absolutely. I think that is a very relevant, the continuum of blood pressure and associated increased risk is something we simply cannot ignore. So there are key interventions required, which would make a difference when it comes to primary prevention of hypertension and stroke. So these key interventions, Dan, where do you think we should start, or where should we place more emphasis?
It's a wonderful question, and I think a very, very appropriate question. I'd like to kind of say that Professor Poulter, Professor Martins have answered part of that question already. Just this mere fact, and you have too, by bringing this panel together. This is a panel, not a debate, not an argument. We're all greatly in agreement. The leading organizations coming together, bringing in and recognizing that blood pressure, as Neil said, blood pressure is this is here. Sheila said, we can do something about this. And by all coming together, every time you turn around, we have this intervention of awareness. And kind of adding to that just a little bit more, Neil brought up the importance of blood pressure measurement, easy to do. So take it one step further. We all know our numbers. So I'm going to add to the COVID-19. Some of us will never know if we have COVID at a particular time or not. And we know that we've had it measured, perhaps we've been screened, but we don't know, and we're not lining up as we used to with regards to all the screenings. But for blood pressure, we're all set. Know your number, but very important, get your blood pressure measured, know your numbers, and get it done accurately. And I think this is all a consistent message that we're all saying. And so with this consistent message across globally, I think it can actually do something. Accurate blood pressure measurement, knowing what it is, increasing that awareness. One thing that we have done, this for World Hypertension Day, as a matter of fact, is have a children's art contest. And unlike many things, blood pressure is something that affects all of us, all ages. And we have got children to come in to put in to do their artwork, regardless of what country or what place it comes from. So if we looked at the written word, we wouldn't understand very much of it. But if we look at the awareness, we look at the artwork, we're able to determine this at an early age. And you're seeing that children being aware of blood pressure, being aware of the increased risk of stroke, putting that together. And we were very, very, very pleased that we think that this type of campaign, starting at an early age, improving that awareness, I think is probably the big intervention in our point.
Yeah, I think that is absolutely an excellent approach to start that from school ages onwards. That is not something for the elderly to start realizing this is now something to take care of, because I do think there are many middle-aged adults that are being missed who have hypertension without any symptoms. And even if we can start it from school ages, I think that's a great initiative by the World Hypertension League. Dan, a quick follow-up question. You mentioned that blood pressure should be measured regularly. How regularly should adults measure their blood pressure?
God, boy, that's the big question, right? And I guess in one sense, I can give you kind of a cop-out answer. Whatever your resources will allow you to do. In some places, it's there. But now we have the technology that's got so good. If some people can do home blood pressure monitoring or doing self blood pressure, it can be very, very regular. And depending on that type of equipment. So I think that's one of the challenges I think that all of us have, particularly on this panel, is to make sure that we provide the resources and the availability to actually do this. But at this point, I think there's opportunities to come forward. And I think there's a good thing for us to do with a consolidated awareness message. One example, just to throw very, very quickly, if you ask people all around the world how much do they weigh, they typically will know. And many people, even in some of the less income countries, still have home scales in their home, bathroom scales where they stand on, so they know their weight. So weight's not a problem. Perhaps we could mimic something like that and get there. But a very important piece is the accurate weight. So you don't want some magic machine or something. We want to be measuring blood pressures accurately, which again is the kind of thing that May Measurement Month is focused in on, is getting that accurate blood pressure measurement. Great follow-up, I agree.
Right, great response. I do think accuracy is some of the major challenges. We may get back to that a bit later, but let's, thank you, Dan. Excellent response. I want to also direct this same question to Bindu in terms of interventions to make a difference. So Bindu has been working also on ground level in India, and I think responses from you would also be very important from that perspective.
Thank you very much, Alka. And really, I would like to voice what Dan has said. I feel hypertension and along with it, the stroke, both are big public health challenges. As Neil has put, the amount of people, number of people dying with these diseases is enormous, but then it's not really put across. Most of the times in our public health campaigns, what we see is that hypertension is essentially asymptomatic. And that's the reason most of the times patients, the individual does not feel that it is necessary to be treated for it. And that's where we should be pinging on the awareness that hypertension is one risk factor. And there are a multitude of causal factors for hypertension, which we can address. And there's another very important thing here, that there is a cross-cutting benefit of all of those risk factors. If you would just see whether it is decreased physical activity, increasing body weight, increasing salt consumption, decreased intake of vegetables or fruits, alcohol consumption, and tobacco products, all of these have cross-cutting benefits. So NCDs in general can be addressed in a good way if one puts in the campaign. And school is the best way, as Dan has said, that we run our school campaigns. And I feel that When we're doing the school campaigns, it is also very important to have community engagement. So if you're doing it in a school, it is necessary that we take the school officials and we have them that their canteen should not have high salt stuff there. There should be healthy diet in their canteens. They should also have physical exercise into their school curriculum. So a little bit of everything, you know, it's like the absolute risk of every individual goes down if this little bit of a small change they do in their daily routine. And that shift from the single risk factor to an absolute risk factor is very essential. And in most of, if I may just add, Alta, that in most of the screening processes also, most of the times we see that screening is done, hypertension is detected, and then what? Usually a behavioral counseling as well as directing the patient and either to a community center, community program, or to a hospital addressed clinic. That is not done. So screening is done, hypertension was detected, probably some medication was given, and the patient stops it after some time because the patient has already taken the medication, his blood pressure normalizes, and then he doesn't know where to do, what to do, because his blood pressure has become, and that suboptimal blood pressure management is an extreme big challenge. And I think altogether we need to face that as well. And home monitoring, as Dan said, is excellent for that. I think probably from the very beginning, we can initiate the home monitoring so that they know that once they stop the medications, the blood pressure is shooting up and they need to take it.
Thank you. I think that is really a comprehensive response, Bindu. You covered several important aspects. I think one thing that's really important is that question from once high blood pressure is detected, let's say in an awareness campaign, this whole pathway that comes until control of blood pressure is actually reached through medication and throughout the whole cascade or process to go to a general practitioner to get a prescription that actually does lower blood pressure appropriately. There are so many things that could go wrong along that way. And that is why we see this problem that even though we have, for example, in some countries, higher awareness of, let's say, 60%, we still have an issue of only 20% of people with hypertension having their blood pressures controlled effectively with medication, or even much lower in other countries. So we have to, I think home blood pressure monitoring is one way in which a patient can engage with their own health and encourage also to monitor it themselves and discuss that with their general practitioners. But let's not jump the gun. I would like to address the next question to Mayowa, and that is in terms of the shift. We need to make a shift in governments, not to push for the budget for hospitalized patient or established disease, but to change the focus to primary prevention. How do you think we could make a case for governments to focus more on primary prevention?
Thank you very much. Well, hypertension is such an enormous body that affects almost 1 out of every 2 or 3 adults in different parts of the globe. In Africa, for instance, for those who are older than 25 years of age, it affects 1 out of every 2 or 3 adults. And because it's a silent killer, meaning that it's there silently, undetected, but it's also very deadly and very dangerous and could actually cause catastrophic things like stroke, which could be fatal, disabling, and in fact, economically catastrophic as well, and life-changing completely. So the best way to tackle it, because once a stroke has happened, you can hardly reverse all the losses. There are indirect losses, apart from the health consequences of stroke, which is just one example. Hypertension can also cause heart failure, damage the heart, damage the kidneys, can damage the eyes, can do so many things, can cause dementia, can cause so many things. So to prevent all this from happening, and knowing fully well that if you are just taking those who are already suffering end organ damage, you are only dealing with a tip of the iceberg, perhaps less than 1% of the problem. So it's a lot wiser to really deal with the entire population by way of primary prevention. That way you mitigate the losses. And in fact, while you're doing that, you are also preventing usually other comorbidities, of hypertension itself. Because when you want to do primary prevention of a stroke by dealing with hypertension, you will also be dealing with other related conditions like diabetes mellitus, like obesity, dietary issues, exercise. And in fact, going back to a life course approach, including school children and all that, you already start teaching them how to eat healthy, how to exercise, and you also create an enabling environment. So it's the only way really of dealing with the burden of hypertension, which is extremely enormous, and of its consequences, is by primary prevention, because you really cannot muster the resources that are required to deal with it if it has already caused the complications. And in fact, if you still fail to deal with it when it has caused complication, it can still the complication can still come back. Recurring stroke can happen. So really, it's important to deal with this root problem by engaging everyone. So prevention is cheaper than cure in every way one can think about it. Now, you mentioned what challenges would governments be facing? Well, the first challenge governments will face is that it is an enormous burden. I mean, if something is affecting 1 out of every 2 or 3 adults, then we're talking about billions of people across the globe. So it's enormous. But what is the easiest way to deal with it? Well, if it's everybody's problem, find a way of involving everybody in dealing with it. Empower people and mobilize resources from across all sectors to make sure that diagnosis, detection is increased, and of course treatment as well, and lifestyle interventions are all done properly, and then monitoring to ensure that control is feasible. And of course, this is possible now with point-of-care devices for measuring, and not only that, with social media and other ML facilities, we can help us to engage people. So it's really doable with the technology that we have if we prioritize it. And why not prioritize it? If we know that this is the leading killer globally, some diseases come and go, but this is here to stay, and we just have to deal with it. And the consequences are devastating. Thank you very much.
Thank you. I think you also touched on some key aspects there. I think one thing you mentioned that wasn't mentioned before is that we live in an age where we have lots of new technological developments, and I think mobile phones is of course one way that's been penetrating low resource settings globally. So that is an opportunity. We should probably see how we can extract much more benefit from that. And Sheila, I want to also direct to you this question on how we can engage better with policymakers and governments to prioritize prevention. How do you think is that possible? I think now during COVID, especially governmental budgets are under severe pressure. Can we make a case? You can speak also from the situation in Brazil.
Yeah, well, I think it's very important to convince the Minister of Health that it's important to act in risk factors to prevent the cardiovascular disease. I think it's our duty as specialists and health professionals to convince them and to show them how to modify these, suggesting evidence-based and cost-effective solutions. So what we did here in Ministry of Health, we showed them that the burden of stroke is increasing in the world, including young people, including people with mild cholesterol elevation, including people with mild blood pressure elevation. And we showed them that the strategies to decrease the burden has failed in the world. And the numbers continue to increase in low and middle income countries. So we have always the strategies to act in high risk patients, but it's not working because the burden is increasing. And we know that 80% of strokes occur in people with low and middle cardiovascular risk. So we discuss globally World Stroke Organization project to try to cut the stroke in half, and together with this, working with World Health Organization strategy, HEART strategy, to teach health professionals how to measure blood pressure, try to change for electronic device to measure blood pressure, how to achieve the goal, because this is a huge problem. And we know that patients in low resource setting are younger with the stroke. We can see here a very different scenario in public hospitals when we receive 80% of stroke patients, and in private hospitals. In public hospitals, you have the middle age for the stroke is 60 years old. In private is 72 years old, as the developed world. So we need to start early to prevent. We have several untreated comorbidities or undertreated, as hypertension, diabetes, dyslipidemia, and atrial fibrillation. And we have low adherence to the treatments, lack of recognition of risk factor by the doctors, lack of knowledge by the population, lack of adequate medical assistance, in failure to achieve the goals. And what goals? I saw a question in the chat asking if we should treat patients and maintain blood pressure below 130. We are doing this in patients with stroke and for secondary prevention, but for primary prevention, we don't know yet. And we know what we need to implement. Bindu told about Mayoa also. We know that we need to teach people how to eat better, lose weight, get active, reduce blood sugar, stop smoke. How to do this? We are using the mobile app, the stroke riskometer, created by Out University by Valerie Fagan in New Zealand. Where people can calculate their own risk factors, can evaluate their own risk factor and calculate the risk for the stroke in 5 years and 10 years, the absolute risk and relative risk compared with people from the same age and sex. When they finish the evaluations, a free app available in Apple Store and Google Play, when finish the evaluation, they will see their own risk factors. So it's important to recognize our own risk factors. And the app suggests how to modify their risk factors. And once a month or each 2 weeks, send messages to remember, you stop smoke, we start to do exercise, trying to motivate people to modify risk factors. So this is one strategy. And the other one, together with HEART's program from World Health Organization, the idea is a gradual, slow, and monitored change in the assistance in primary care, focusing flow charts and simplifying the process through protocols, very easy protocols to know what drug I should start, what I should achieve, and in 1 month I will review the patient to see if the patient decreased the blood pressure. Also, counseling lifestyle modification with a strong educational part for doctors, nurses, and health community workers. So together with this change in primary care assistance, we are starting implementation here together with the Ministry of Health in Brazil. We are implementing a clinical trial to evaluate the strategy to cut the stroke in half. That is to act in middle risk patients, so patients with blood pressure 121 to 139 of systolic blood pressure plus 1 modifier risk factors will be randomized. First is the units, the primary care units in cluster to use riskometer together with health community workers or not. And after randomize individual patients for polypill with 2 antihypertensive plus statin against placebo to know if you can change stroke, cardiovascular disease, mild cognitive impairment, and cardiovascular death. We are starting here in 8 units in Porto Alegre, and after in 60 units in Brazil, 13,000 patients to prove the concept. I hope you can do it. We are working together with the Ministry of Health, World Stroke Organization, and World Pan American Health Organization on this. And we are teaching the population that your choice today will promote your health tomorrow. So to aware them that modified lifestyle risk factors can decrease the burden of stroke.
Excellent work. It should be a very exciting trial.
Yeah, thank you. And COVID really decreased the capacity to assist those patients. So it is a challenge in this moment, but we are doing. Yeah.
You have touched upon some aspects that Dan and Bindu and I think Mayoba also mentioned, and that is to reduce risk throughout the life course through lifestyle measures. But we know the persistent high blood pressure cannot be covered by lifestyle measures alone, and then we need to go for pharmacological treatment. So Neil, I would like to ask you, you've mentioned that medication for blood pressure is globally generally quite affordable. So what is the reason then that we do sit with the issue that there's so many people that don't have blood pressure under control if blood pressure medication is so cheap or affordable then, at least in most places?
Well, I mean, one of the rationales for my measurement month was if you look at the awareness rates, this goes back to the Pure study and it's a little bit out of date now, but that was under 50% of people were aware of it, that they had high blood pressure. So it occurred to us that you can mess around with the small proportion of patients who get treated, because it's even less than that, and try and optimize their care. But actually, you're not going to make a hell of a difference. The biggest difference you're going to make is to make people aware and thereby start them on treatment. So it's the detection thing which we thought gave the biggest opportunity around the world to improve control ultimately by finding people. And I think it's probably been mentioned, and it was mentioned earlier, what are you going to do? Once you've found it, you've then got to do something about it. Yeah. And that has the financial implications and the drugs. And groups like Resolve to Save Lives are working hard about the distribution of drugs. And you too are involved with trials where distributing relatively cheap drugs, which have got 2, 3, maybe 4 components, which will lower the blood pressure effectively. We've got to get them out there. In the first instance, working out the best fourth line agent is, you know, you're messing with a tiny, tiny number. As mentioned earlier by Sheila, that most people are in a relatively normal range of blood pressure. So the extreme resistant hypertensives, I mean, whilst as a clinician, you know, in the clinic, yes, I was dealing with it, that isn't the bulk of the problem. It's about finding JOSOP, the ordinary hypertensives. And so that's why MMM was born, really.
Yes.
Mm-hmm. And Dan, in terms of medication for hypertension, the different guidelines these days advise not only to go for a single antihypertensive agent, right? It's to go for, most patients need more than one agent to
Sure.
control blood pressure. Is that right?
Yeah, beautiful. And I think, but I do want to kind of come back, just like you will too, back to Neil. I think that's the piece. Let's don't dicker over, you know, the drugs. Let's don't look at the different classes. Let's get the people that are hypertensive, that aren't being treated at all, into something, and to move in that. We can move in that other direction. I think your comment, Neil's comment, I just think that's what's really there. And maybe, and Neil, if you'll allow me, I would like to put in that word of awareness, increase the awareness, but also maybe include that awareness that if you have high blood pressure, that you should be treated. So not just that I have something, you know, well, you know, now you're going to die. No, or you're going to have a stroke. Now let's say I have high blood pressure, I need to be treated, and get the patient involved into what you want to do too, is to get them knowing they have high blood pressure, but they need to be treated.
Yeah, it's an education issue, isn't it? We need education, not only of the doctors, but also of the population. So it's their expectation that if they've got the problem, it's going to be treated. I agree.
Yeah, I think there's that component of some patients denying, once they've been found out that they have high blood pressure, they sort of want to deny that and not go for treatment. So that's that first thing in terms of patient activation, to go to the medical doctor then after detection, and then to continue their treatment if they get treatment. And on the other side, we also have the challenge sometimes where doctors measure high blood pressure and don't act on it. So we have that sort of inertia from the medical profession side. So we have all these different barriers to actually get blood pressure down. But I do agree with all awareness, and that is why we are also here today, and why World Hypertension Day on the 17th of May was born, is to create that awareness and to really build on that also with my measurement month for the full month of May. So thanks for your excellent responses. I would like to continue with the next question to Bindu, and that is now with COVID-19. The COVID-19 pandemic has obviously created a lot of challenges, but it also created some opportunities in terms of hypertension and stroke prevention. How do you see that? Do you think there are some opportunities that we now have looking at the COVID situation?
Thanks, Alta. Yeah, indeed, COVID-19 has created a global health crisis, and that has impacted the way we perceive the world and our everyday lives. Everything has changed. As Sheila just said, even the research protocols are not being, we are not able to carry it out in the way we would have. And at this point of time, we know that all the resources are being directed to managing COVID-19, and probably rightly so. But then it is at the cost and having a negative impact on the time-sensitive diseases, I would say, like stroke and myocardial infarction. So there's a setback there. The home screenings, the community screenings, the village camps, the mobile vans, the acute stroke treatment, the thrombolysis, the thrombectomy, and also the post-rehab care. So, the continuum of stroke care has been compromised. And while this is going on, and then it's been going on for more than a year now, and we know that last year, probably during this month, last year, 2020, the World Health Organization had done a survey, and it had shown that almost more than 150 countries, almost 50% did not have hypertension screening being conducted. So that's the impact which COVID-19 is having. But over the time, we can see that the healthcare system has improvised itself and is making changes in the way it works, so that we accommodate the non-COVID diseases and the non-communicable diseases. And that has given us an opportunity to learn and probably to extend that care in the post-COVID era as well. And the first thing I would say is that the social distancing. The social distancing brought us face to face with telemedicine. And this existing telemedicine, I would say this panel of discussion which we are having today, I think probably in a pre-COVID era, we would not have had, and we had to be in physical person to person. And this is great to have an expert panel to talk and mingle and get in their ideas. So the social distancing brought in the telemedicine, and we are now introduced to something known as digital health. The digital health, the telemedicine, which was probably caught in the complexity of the regulatory issues, now got a go, and it is being used for the care of patients. And that has solved, I would say, when I look at it from my point of view, from my place here, the rural healthcare, the shortage of healthcare workers at the rural front, where the patient from that area can connect to a person, a doctor, a physician at from the remote area to the center. And even I would say monitoring of hypertension and the other risk factors have become easier now. It will become more easier as time passes, because telemedicine has become a cost-effective. It has become, you can give a personalized health care to the person there. You can get the blood pressure, you can get the diabetes monitored. And as Dan said, that you have a weighing scale, you can see how much, what is the weight of the person there. You can probably connect with the persons with non-communicable diseases and empower them and see that they have the power over their own risk factors. You can get that under them. And technology is being used now, and I think it will go a long way, and it's going to be used in the post-COVID era as well. this COVID-19 also showed us how unprepared we were. So as time is passing, now we know the COVID-19 also showed us that how good we could, the public and the private sector could mix together and bring in fruitful healthcare, innovative ways to deliver healthcare. So in the same way, one should probably, for the hypertension, for the stroke, the public as well as the private, let us say the stroke support organization in that community area, the community organizations, they should group together, because that's what is going to help. And it's a long way to get the awareness across. So this public-private infrastructure, the grouping of people together to see that the things can be delivered well, that is the urgency, the action, urgency in the care has taught us that, as Neil said, that this is also an epidemic and it's going to increase as time passes. COVID-19, we would probably able to get over it, but not probably the hypertension and the stroke if we do not work fast. And it is very important that we engage the community the way now. You would see that in COVID-19, it's not only the intensivist and the physician, it's everybody actually. After a period of time, the memes are going on that I really don't know what specialization I am in, because I am working in a COVID-19 ward now. So, but then it is bringing out fruitful results. It's going to be short lasting and we will wage over it. And I think that's the way we would look over it. Thank you so much.
Thank you, Bindu. Dan, I have a question from the audience for you in follow-up from what Bindu have just said. It was asked, in addition to awareness, are there other novel interventions such as social marketing that could be implemented? For example, behavior change, measuring frequently blood pressure. They say that won't happen only with awareness and education. Does any country have experience using social awareness in preventing hypertension? In other words, going beyond the campaign.
Also, I think there's some great examples. I'm sure everybody on the panelists could be addressing that particular question. And one of the things that we had worked with World Hypertension Day is kind of said, do whatever you want to do, celebrate, if you will, or recognize World Hypertension Day in any way that you would like. And we were a little bit surprised at how the different countries did just that, kind of increase their awareness, some of them with a traditional health fair. And when you see healthcare providers out doing something like that, it kind of gives it some good credibility. We've seen a number of, and I know Neil and I and Alta, we've all had this conversation. You can get celebrities, you can get, I hate to say politicians, because we don't want to bring them in, but politicians, all kinds of people with a consistent message, letting everybody know that there's not, that it's not okay, that some people don't do well with elevated blood pressure, but getting that kind of campaign, and some things work better in some countries and some populations than do in others. But I think, and it's also an opportunity to get the community involved and to get the whole population involved. And what can you do? We artwork for children, or maybe different other types of groups, sporting event celebrities. I think there's so many different ways that we can have this consistent message. I think that will go very, very well. And I'd just like to pile on to what Bindu said very, very nicely. That was a beautiful presentation about the effects of the pandemic. But the pandemic really has challenged us. And I'd like to use a word that Miawa said that is more as a challenge. When the pandemic came, people prioritized their health and they chose, I'm more worried about COVID-19 than I am about blood pressure. I'll put my blood pressure on hold. Quite frankly, a number of practitioners, I'll even include people at our place, not mean, but did that too. They said, okay, we're going to deal with COVID-19 right now and good luck with your blood pressure. And I think we want to change that. That was kind of done. That prioritization, I think, did hurt. And one of the things that we did here, we looked at the gap already, there are some populations, just like everywhere we have high-risk populations, that there's a gap between their blood pressure control, their treatments and stuff. It's just a gap. We saw that gap increasing during the pandemic, in which their control rates were getting worse, the treatment rates were getting worse for our population that was at the greatest risk. Another place that we saw the challenges were the randomized control trials that were ongoing. Basically, if it was hypertension, or forgive me, if it was neurological or cerebrovascular, we almost put those trials on hold. So if you were in that trial, we just put you on hold and kick the can down the street. So there are challenges to research, challenges to everything. But I think the opportunity was beautifully described. But we need to work into the system of care that we don't prioritize when we have something like this, that blood pressure is the top priority, and we need to figure those systems that were very nicely presented to do that. And I think that's the great opportunity, so that we don't prioritize, at least away from blood pressure. So apologize for that long rendition.
Yeah, I think that was a clear message that we actually got over this past year. We can't forget about hypertension during these times. Neil, did you want to add something there?
Yeah, I'm sorry. I was just going to say something a bit specific to blood pressure management. And I thought one of the frightening things, the challenges, was the early scaremongering about the use of RAS blockers. Yes. I think that's been universally kicked into touch, but for a while that was a terrifying, erroneous message that was getting out there. And the other strange spin-off, the good things that I think have come out of, if you can have a pandemic being good things, is that about half my patients have taken the opportunity to lose weight. Half of them say, oh, it's because of COVID I've put on weight. The other half said, because of COVID, I've had the opportunity to exercise. And some of them, in the clinic on Wednesday, someone said to me, I was terrified. I'm 114 kilos and I saw who was dying of COVID. I have lost 17 kilos. And there is a spin-off here. There's a group of people who have spotted, and I think that's going to become increasingly clear. People died of COVID, are largely driven, one of the main drivers was overweight. So that will give us a spin-off, a beneficial spin-off to hypertension, therefore stroke. Hypertension being the biggest risk factor for stroke. So there's a paradoxical benefit from that.
Yeah, we should probably use that as a stronger messaging tool. Yeah, good idea.
Yeah.
I have a question from the audience. This is a bit away now from the COVID pandemic, and this is mostly to colleagues in low and middle income countries, where it is asked from the audience whether you could give examples, preferably from LMICs, where in recent years investments in hypertension control and stroke prevention have been made successfully. So what were some examples where we were able to address this, and what was facilitated this process? Is there something we can copy that worked in some countries that we can replicate in others? I want to start with Myova. Do you have specific examples that you could share with the audience?
Okay, well, what I'm doing is, okay, let me put it this way. It would have been great if we had such examples. Unfortunately, that is not the case. For instance, in Africa, about 30%, only 30% of those who are hypertensive are aware in the first instance. More than 60, about 70% are not even aware. And only, surprisingly, only 7% are controlled. 93% are either not aware, or they're aware they are not on treatment, or they're on treatment, they are not controlled. So that is this current situation. And the other problem is that hypertension is not even monitored in such a way that you can adequately track the burden. Neither are the complications and even mortality accurately monitored in low and middle income countries to be able to say, okay, at this point, we did this intervention, now this is where it is. So anyway, this question is very important because it's telling us what gap exists and what we need to do to fill the gap. And in fact, it's telling us we need to probably make a few examples, by collecting adequate data, by engaging in population-wide aggressive intervention that involves all stakeholders, to ensure that blood pressure is controlled. And then by measuring the burden of the complications of hypertension, like stroke itself, and seeing that this comes down. And then this can now be Chinese examples to other low and middle income countries. And the easiest way to make it cost effective is to involve everybody. And the most powerful weapon to use to involve everybody, including those who are payers and funders, who are going to commit resources into it and who are going to draw up the priorities, is education. Education remains the most potent tool to change the world.
I think that's an important tool as part of this whole awareness thing. For example, with May Measurement Month, and Neil could elaborate there, is I know African countries have really been very enthusiastically participating in May Measurement Month, and I'm so glad about that, because that could be an entry point where we can push this through. I know there's been also some other examples from low and middle income countries. Maybe some of the others can elaborate where we've seen successes. I know, for example, the salt legislation in some countries have resulted in a lower intake of salt, which have a population-based effect in lowering blood pressure. In South Africa, I know this was legislated with it seems like success in terms of the monitoring to date. Are there others that maybe Sheila or Bindu or Neil seems to also put up his hand would like to mention? First one, Neil, you have your hand up.
I was going to say, not low-income country, but Portugal is one of the best examples where they've had a huge drive on salt, huge drive, and stroke has come down brilliantly. I mean, before that, the Japanese did it. They've had a massive reduction in their salt intake, massive reduction in stroke rates. So they're other examples, not low-income countries. I agree. But then also there's another thing where in the World Heart Federation roadmap, there were some examples for Latin America. Probably Sheila knows them in Latin America, where they've had demonstration projects which have shown the benefits, I think, of salt restriction, if my memory is right. Sheila, does that ring any bells with you?
Yeah, this is part of the World Heart Federation, together with World Health Organization, to decrease the blood pressure across the globe. So the Global Hearts or Hearts program, I think is the main action across the globe to decrease blood pressure. That includes negotiate with governments to decrease the South in industrialized products. Here in Brazil, we did this several years ago. We need to do more, but I think the governments are trying. And in Latin America, several countries, Chile is another good example, and Uruguay also, that the governments are negotiating with industry to decrease the South in the industrialized elements, industrialized foods. And here, I think the implementation of global hearts in low and middle income countries that is cheap is just, as Mayoa told, education is the key. Education about what the goals, how to measure blood pressure for doctors. The medication here is free for hypertension, so is low cost or is free in several countries, and educate the population that know your numbers is very important to push the health professionals to treat those patients with or without medication, but I think the medication is important too.
We have a few minutes left. The time has really flown past. I would like to give Bindu also opportunity with that question in terms of, I think it's so important, the successes that we've seen in countries. Do you have something that you would like to share, Bindu?
Yeah, I would second whatever has been said, and I would just like to emphasize that whenever we are having these awareness campaigns, again, I would like to put in that it is very important to address the issue of the risk factors which could lead to hypertension, but also to emphasize that hypertension need to be treated. Every time that has to go into the public, that hypertension is just not recognizing and knowing that you're hypertensive. And secondly, as healthcare professionals, I feel that all of us to stand together and get this opportunistic screening. Each and every patient who walks into the hospital for whatever reason it may be has to have his blood pressure checked. that has to be mandatory. That should be made as a rule, and it should be underlined. And I suppose most patients, most individuals would have that opportunity, and hypertension could be detected in that manner as well.
I cannot agree more. I think you've given all such excellent responses. We now have 5 minutes left of this webinar, and I would now like each of you to give in 1 minute a short indication of what would be your key intervention to reduce hypertension and stroke. If you had one key intervention, what would that be? I'll start with you, Dan.
Okay, good. Thank you, Alva. Very, very quickly. Again, I'd like to go back to the awareness, the knowledge, the ability to treat. One of the things that we did add very recently is a very, very simple thing, a very, very cost effective. We've spoken about awareness, but also among the providers. Basically, how do you measure blood pressure? What's the proper procedure for measuring blood pressure? A very simple thing. And we did it with just very, very simple, and each of you, everyone on the panel has done this type of thing, but we got this in our particular case in our region of the country, which is the stroke belt of the United States. We implemented basically just simple blood pressure measurement, but we called it a hypertension policy, just writing down, this is what you do, all the things that each of you know for an accurate blood pressure measurement, and talking about the hypertension team and how they do, and just simply said, this is what your clinic should do. And the cost on that was we gave, if you did it, we gave you a certificate that says your clinic complies with this therapy. Just something very, very simple. But I think going back to the theme of an accurate blood pressure measurement and awareness.
That's a key point. I think that's a mistake that's being made in many GP practices and everywhere. So it's very important to refresh on how to do it correctly. Sheila.
Well, I think it's very important to know how to measure blood pressure, but it's very important to know the goals, because the health professionals don't know. It's very common to say, this blood pressure is good for you, is 150 systolic blood pressure, but for your age is good. We cannot accept this, and I think the education is the key to improve the control of hypertension.
Absolutely. Thank you, Sheila. Bindu?
As blood pressure measurement is mandatory, and I would also add that community engagement is absolutely necessary, so that we engage with persons with NCD and see that they are empowered to get a hold of their risk factors on their own, and that should go a long way put all together.
Very important, community engagement, absolutely. Mayowa?
Yeah, so if I'm going to put it, I would still say education. But if I want to put it further, I will actually say that education implies ICE, not just information, communication, and by communication it means a two-way thing. You know, using the best channel that is available, and people can be reached through virtual communities on Twitter or social media. You can engage so many people. You can engage some people through applied theater, through movies and things like that, or even football or whatever it is that people like. You have to use what they like, the medium they like, to speak with them. Policymakers, you have to use economic case to communicate with them. You know, or even a political case. What are they going to gain politically if they're able to control hypertension in their countries? Or what are they going to gain economically if they're, so that you have to use their language, the language of the listener, you know, to really educate. That's the only way that they will get the message. But it doesn't end there. You must also empower. So ICE, meaning you must provide an enabling environment. And this purely requires a multi-sectoral engagement. If you talk about healthy diet, that means you need to influence the entire food value chain. So that's exactly what is required. It's education, but broken down, really you must empower and engage all stakeholders. An example of that and why this is important is it's not just important to say, oh, start to take some medication to control your blood pressure. You need to say, if you don't take it, these are the consequences. You can show graphic examples of what it is, okay? And then they know that, oh, this is really important. Even though this is silent, I'm feeling well in my body, but if I don't do this, this is going to be the consequence. Then the other major issue is that some people think, oh, it's like you are treating malaria or you're treating headache. Once you take your medication for a while and your blood pressure is normal, it will remain normal forever. We are not yet there. Of course, hopefully, one day we will be able to get there. Give one shot and everything reverses. Of course, it's best to prevent it developing, but we know that you have to take your drugs or your medication for life, along with other lifestyle medications. So,
absolutely, yeah. Very important point, lifelong medication. Before I go to Neil, I would like to acknowledge firstly the audience and say thank you very much. We've had so many questions and we've tried to answer them along the way, but we couldn't get to all of them. But it's really fantastic to have such a lively audience. Neil, last word to you.
Thanks very much, Alta. I've got to go for one intervention. I'm going to go for global salt reduction. I think the Japanese experience, the Portuguese experience, if we had global powers to cut salt in the diet dramatically, I think we make a huge difference to high blood pressure and to stroke. But I'm also persuaded by my colleagues that it's very important to get the blood pressure measured. And so with that, I don't know if it's possible just to share that last slide, this is an advert, I confess, this is an advert for May Measurement Month, which has had 3 campaigns so far. We've screened over 4.2 million people around the world of 17, 18 and 19. But there's another campaign starting this year. And if we've got that last slide, if anyone can share it, this last slide just tells you that May Measurement Month is back this year. And it isn't just in May because of COVID. May Measurement Month, call it My Measurement Month. It's any time from May until November. And if you can screen your patients, I would just be overjoyed. Anybody in the world, set up a system. We've got national leaders in over 90 countries have signed up this year. Please join them. If your country isn't involved, please get involved with us. And we look forward to you joining in this campaign because it really is making a difference. We don't just measure it. We give tips on non-pharmacological advice and we facilitate people going on to how they need follow-up. And we hope that will help and covers several of the things that people have said. So my very best wishes to everybody. And Alta, thank you for giving me that opportunity to advertise May Measurement Month this year. Very best to everybody.
Thank you, Neil. I think May Measurement Month is something that's of benefit to all. We need to measure blood pressure. We need to get awareness out. It will have an effect on all cardiovascular outcomes, including stroke. Finally, I would like to give a warm word of thanks to all of the panelists. You've been excellent and we've had such interesting conversations. I hope we can do a round 2 at some stage, but thank you very much and take care, everyone. Please measure your blood pressure.